Welcome to the deep dive. Today, we're tackling a really important topic in newborn health.
We are. It's vitamin K deficiency bleeding, or VKDB.
Right, VKDB. We're aiming to give you a clear, kind of high-yield guide to this condition. We've looked through the sources to pull out the key stuff you need to know.
Exactly. The mission here is to distill the crucial information about VKDB. You might have known it as hemorrhagic disease of the newborn, but VKDB is the term we tend to use now.
Okay.
So whether you're studying medicine or maybe you just have a strong interest in neonatal health, we want this to be clear, memorable, and, well, useful.
So VKDB, vitamin K deficiency bleeding, why the name change from hemorrhagic disease of the newborn? Is VKDB just more specific?
It is, yeah. VKDB points directly to the root cause, not enough vitamin K. And vitamin K is just absolutely vital.
Vital how?
Well, the liver needs it to produce some really key clotting factors. Think of them as the body's little repair kit for blood vessels. Without enough vitamin K, that kit is missing some tools.
Got it. So how are we structuring this deep dive? What's the plan?
Okay, so we'll start with the definition of what it actually is. Then the etiology of the causes.
Right.
Then we'll move through risk factors, pathophysiology, which is how the deficiency actually causes bleeding, and then differential diagnoses. So what else could it be?
Makes sense.
We'll also touch on epidemiology, how common it is, clinical features, what it looks like, investigations, management, prognosis, and any complications. We'll try and keep it clear, maybe offer a few memory tips.
Sounds good. Okay, let's kick things off then. The definition. What exactly is vitamin K deficiency bleeding?
Okay, so VKDB, put simply, is a bleeding disorder. It happens in newborns, and it's because they don't have enough vitamin K, or sometimes there are other issues with their blood clotting.
And newborns just have lower levels naturally.
Yes, that's a key point. They're born with less vitamin K than older kids or adults, so their blood doesn't clot quite as well right at the start. And this is particularly true for breastfed babies if they don't get that vitamin K supplement, especially if the mother was on certain medications, like some antiepileptics.
Right, the medication link.
Yeah, but it's important to remember, certainly here in the UK, there's a preventative vitamin K program offered to all newborns. And that's made a massive difference, reducing cases hugely.
Okay, so it's about low vitamin K impacting clotting. Where does vitamin K normally come from?
Two main places, really. Diet, thick green leafy veg, and importantly, the bacteria that live in our gut.
Ah, gut bacteria. But newborns don't have much of that yet.
Exactly. Their gut is pretty sterile initially, so they don't have those bacteria producing vitamin K for them. That's another reason their levels are low. So fundamentally, all newborns start life with this vitamin K deficit, which puts them at potential risk.
Okay.
And we tend to classify VKDB based on when the bleeding starts. There's early, classic, and late.
What are the time frames for those?
So early is within the first 24 hours of life. Classic is usually day 1 to day 7. And late VKDB happens between week 2 and week 12, sometimes even a bit later.
And you mentioned one is more serious.
Oh, yes. Late VKDB. It carries a higher risk of bleeding into the brain, intracranial bleeding, which could be very serious. That's really why these routine vitamin K protocols are standard practice in most high-income countries.
Right. That makes the prevention aspect really clear. Okay, so that's the definition covered. Now, the why. What are the underlying causes, the etiology?
Well, the main cause is right there in the name, vitamin K deficiency itself. But other things can play a role or look similar.
Such as?
Liver disease is one. If the baby's liver isn't working properly, it can't use the vitamin K effectively to make those clotting factors.
Okay.
Malabsorption disorders are another conditions where the baby can't absorb vitamin K properly from their gut.
Right, like the cholestasis you mentioned potentially linking to late VKDB.
Precisely. Also, as we touched on, certain medications taken by the mother during pregnancy can interfere. And then much rarer, you might have an inherited coagulation disorder that presents similarly.
Okay, quite a few potential contributors there. So who is most likely to develop VKDB? Let's talk risk factors.
Yeah, this is really important for prevention. Generally speaking, the single biggest risk factor, and it's worth stressing this, is exclusive breastfeeding without vitamin K supplementation.
Right. That's key.
Definitely. Other general risks include the mother using specific medications. We'll circle back to those. Prematurity is another factor.
Why prematurity?
Several reasons. Preterm babies often have delayed feeding, their livers might be less mature, and their whole clotting system isn't fully developed yet.
Okay. Any others?
Yes. Also, if the mother has a history of liver disease or certain bleeding disorders herself.
And do these risks differ depending on whether it's early, classic, or late VKDB?
They do, yes.
Yeah.
It helps to separate them out. For early VKDD, that first 24 hours, the big association is maternal drug use. Things like certain anticonvulsants, warfarin, some antibiotics even. Think early onset linked to maternal drugs.
Okay, drugs for early. What about classic?
Classic VKDB, days 1 to 7, is more related to sort of normal newborn physiology, but pushed to an extreme without prophylaxis. So factors like low vitamin K transfer across the placenta.
Which is normal anyway.
Yes, it's naturally quite low. Then there's the low concentration in breast milk, the baby's lack of gut flora, and sometimes just poor feeding in those very first few days. It's the classic newborn challenges.
Got it. And preterm babies we mentioned are higher risk overall.
Yes, they are, due to those factors like delayed feeding and immature liver function.
Okay. And then late VKDB risks.
Right, late VKDB, weeks 2 to 12. Some studies suggest warmer temperatures might be a factor, though the reason isn't totally clear. More definitively, underlying liver disease, like that undiagnosed cholestasis we talked about.
Which causes malabsorption.
Exactly. Malabsorption disorders in general are a risk. And crucially, especially in a global context, the lack of vitamin K prophylaxis at birth. This is a huge factor in developing countries where late VKDB is sadly more common.
Okay, that's a clear breakdown of the risks. Now let's get into the how, the pathophysiology. What's actually happening inside the baby's body?
So it comes back to those clotting factors. Vitamin K acts like a necessary helper, a cofactor for an enzyme in the liver. Right. This enzyme's job is to activate specific clotting factors, numbers 2, C, E, I, X, and X. You might remember those from medical school.
Vaguely. The vitamin K-dependent factors.
Exactly, those. And also proteins C and S, which regulate clotting. So if you don't have enough vitamin K...
the enzyme can't work properly.
Precisely. The liver can't produce enough functional clotting factors. It might make the protein precursors, but they don't work. This means the blood can't clot effectively when needed, and that leads to bleeding. Simple as that, really. Not enough key ingredient, the clotting cake doesn't bake right.
Nice analogy. Okay, so vitamin K lack leads to faulty clotting factors, leads to bleeding. Now, if a baby is bleeding, how do we differentiate VKDB from other possible causes? What's the differential diagnosis?
That's a really critical step. Bleeding in a newborn can be scary. And it's not always VKDB. We have to consider other things.
Like what?
Well, top of the list might be disseminated intravascular coagulation, DIC. That's a complex, serious condition where the clotting system goes haywire.
Right. Clotting and bleeding at the same time.
Exactly. Sepsis, a severe infection, can also trigger clotting problems and bleeding.
Okay.
Then there's thrombocytopenia, which is just a low platelet count for whatever reason. Platelets are crucial for plugging holes.
Makes sense.
We also need to think about inherited bleeding disorders, hemophilia A or B, for instance, although they might present slightly differently.
Right.
And importantly, trauma. Could it be accidental or sadly non-accidental injury? That always needs to be considered.
Absolutely. Any others?
Yes. You might also think about things like specific coagulopathies, maternal isoimmune thrombocytopenia, where mom's antibodies attack the baby's platelets, or conditions like necrotizing enterocolitis, or even intussusception in slightly older infants, which can sometimes present with bloody stools. So it's a broad list.
Definitely need a thorough workup then. Okay, let's talk numbers. How common is VKDB? What's the epidemiology?
Well, here in the UK, because of the routine vitamin K administration, it's actually pretty rare now.
So the prevention works?
It works very well. Exact figures aren't always easy to come by because it's rare, but when cases do occur, they're almost always in exclusively breastfed babies who, for whatever reason, didn't receive the vitamin K prophylaxis.
Okay. And the picture elsewhere, internationally?
It varies a lot. For early VKDB, in those specific at-risk babies whose mothers took certain drugs, the incidence used to be cited as somewhere between 6 and 12%.
Wow, quite high in that specific group.
Yes, before prophylaxis for them was standard. Classic VKDB is estimated around 0.01 to 0.44% without prophylaxis. But the real burden is seen in developing countries where vitamin K might not be routinely available or given.
Right.
In those settings, VKDB is a much bigger problem, contributing significantly to infant death and long-term disability.
And late VKDB specifically?
Late VKDB, interestingly, can still occur sometimes even with intramuscular vitamin K, though it's much rarer. The incidence is estimated at maybe 1 in 15,000 to 1 in 20,000 births in places with prophylaxis. But again, much higher where prophylaxis isn't routine.
Understood. Okay, so we know the risks, the causes, how common it is. What does VKDB actually look like? What are the clinical signs and symptoms we need to spot?
It can present in a few different ways, and it depends a bit on the type, early, classic, or late. But the general theme is, well, unexpected or excessive bleeding.
Where might that bleeding occur?
It could be from the umbilical cord stump, maybe oozing for longer than usual, or bleeding from the GI tract, so you might see blood in the baby's stool melena, which is that dark, tarry stool, or even fresh red blood. Nosebleeds can happen.
Okay.
You might also see signs on the skin, like easy bruising or petechia. Those are tiny little red or purple dots.
Right.
And the really worrying one is bleeding inside the head. CNS bleeding, intracranial hemorrhage.
Okay, let's break it down by type again. Early VKDB, the first 24 hours linked to maternal drugs. What does that look like?
So you might see bleeding related to the birth process itself, maybe significant bruising or a cephalhematoma, that collection of blood under the scalp, particularly after a ventus or vacuum delivery, or more serious signs like irritability or even seizures, which could indicate intracranial bleeding. You could potentially see bleeding into the chest, causing blood-stained sputum, or into the abdomen, causing melavina. And if the bleeding is severe, the baby might be pale and tachycardic, have a fast heart rate.
Right, signs of significant blood loss. Now, classic VKDB days 1 to 7.
This often involves bleeding from sites that seem, well, less immediately life-threatening, although still serious. So GI bleeding is common. Bleeding from the skin or mucous membranes, nose, gums. Maybe prolonged bleeding after a circumcision, if one was performed. Oozing from the umbilical stump is quite characteristic too. Think classic newborn bleeding sites, but more pronounced.
Got it. And then late VKDB, you said that's often the most severe presentation.
Yes, unfortunately. Late VKDB, typically peaking around 3 to 8 weeks, classically presents with sudden severe intracranial hemorrhage.
Wow. Oh.
And as we mentioned, it's often linked to that underlying, maybe previously unknown cholestatic liver disease causing vitamin K malabsorption. Because it so often involves the brain, the morbidity and mortality rates for late VKDB are sadly quite high.
That really highlights the importance of catching liver issues early, too.
Absolutely. And giving that vitamin K at birth.
Okay. So when we're taking a history for a baby with suspected bleeding, what are the key questions?
You definitely want to ask about maternal drug use during pregnancy, any anticonvulsants, warfarin, etc. Ask about the gestation at delivery. Was the baby premature? What kind of delivery was it, and was it difficult?
Right.
And crucially, the feeding history. Breast or bottle, exclusively breastfed. For how long? And did the baby receive vitamin K prophylaxis at birth? And if so, was it oral or intramuscular?
All vital pieces of the puzzle. Okay, so we suspect VKDB based on history and presentation. What investigations do we order?
First off, a full blood count, FBC, to check hemoglobin levels and platelet count.
Standard stuff.
Yes. Then, critically, a clotting screen. In VKDB, what you expect to see is a prolonged prothrombin time, PT, and often a prolonged activated partial thromboplastin time, APTT as well. The coagulation time might also be prolonged.
So the PT and APTT are key.
They're key indicators that the vitamin K-dependent factors aren't working properly. There are also more specific tests like measuring PIV-KAP proteins induced by vitamin K absence or prothrombin antigen levels, which can confirm the deficiency.
Okay. And if you suspect internal bleeding,
Then imaging comes in. A chest x-ray or an ultrasound might be used if you suspect bleeding into the chest cavity. And for suspected intracranial bleeding or other major internal bleeds, you'd need a CT or an MRI scan of the head or relevant body part.
great, imaging for the serious bleeds. Okay, let's say the diagnosis is confirmed. What's the management? How do we treat VKDB?
The cornerstone of treatment is, unsurprisingly, giving vitamin K.
Makes sense. How is it given?
It can be given orally or by intramuscular IM injection. In an acute bleeding situation, you want to give it as soon as possible. IM is often preferred because absorption is quicker and more reliable than oral, especially if there's GI bleeding or malabsorption. Sometimes it's given subcutaneously, but IV carries a small risk of anaphylactoid reaction, so IM or SC are generally favored for the vitamin K itself.
Okay, give vitamin K fast, usually IM. What about those babies known to be at high risk for early VKDB because of mom's meds?
Yes, for those infants, the recommendation is a prophylactic dose of 1 milligram of IM vitamin K very soon after birth. That's specifically to prevent early VKDB.
And if the baby is actively, severely bleeding or has an intracranial bleed?
In those really serious situations, vitamin K alone isn't enough to stop the bleeding immediately because it takes time for the liver to make new clotting factors. So in addition to vitamin K, you need to give fresh frozen plasma, FFP.
Why FFP?
because FFP contains all the clotting factors the baby's missing, ready-made. It provides immediate help to stop the bleeding while the vitamin K gets to work for the longer term.
Right, FFP for immediate hemostasis. And what about long-term prevention for all babies?
The standard practice in many countries, including the UK, is that single IM injection of vitamin K shortly after birth. This is particularly crucial for preventing late VKDB, especially in exclusively breastfed infants. It acts like a vital safety net.
Okay. And for those unlucky babies who do develop late VKDB with intracranial bleeding, what's the approach then?
They need urgent specialist care, usually in a neonatal intensive care unit, an ICU. Management involves stopping the bleed, often with FFP and vitamin K, and then managing the consequences of the brain injury.
Which could involve.
It might involve neurosurgery, depending on the type and size of the bleed. And then long-term follow-up is essential, potentially involving physiotherapy, occupational therapy, nutritional support, and developmental assessments to minimize long-term problems.
Okay. So assuming timely diagnosis and the right management, what's the outlook? What's the prognosis for VKDB?
Generally, if it's caught and treated quickly, the prognosis is actually very good.
That's good to hear.
Most newborns respond really well to the vitamin K treatment, and usually there are no long-term complications, especially for the classic form if treated promptly.
But what happens if it's missed or treatment is delayed? What are the complications we worry about?
Untreated VKDB can lead to severe bleeding, as we've discussed. And the most feared complication by far is intracranial hemorrhage bleeding inside the skull.
And the consequences of that.
That can cause permanent neurological damage. Things like cerebral palsy, learning difficulties, developmental delays. And in the worst cases, it can sadly be fatal.
So it really underscores the importance of prevention and rapid treatment.
Absolutely.
Okay, so let's try and summarize the key takeaways. Vitamin K is absolutely critical for a newborn's blood to clot properly.
Correct.
A deficiency leads to VKDB, which can cause serious bleeding. But, and this is the good news, preventative measures, like that routine vitamin K shot, are highly effective.
Very effective. And timely treatment works well if bleeding does occur.
And it's important we understand the different types early, classic, and late, and their specific risk factors and presentations.
Definitely. Knowing the patterns helps with diagnosis and prevention strategies.
And perhaps a final thought to leave our listeners with. Maybe consider the global picture, the impact that simple access to vitamin K prophylaxis has.
That's a really important point. Where it's readily available, VKDB is rare. Where it isn't, it remains a significant cause of infant mortality and morbidity. It really highlights health inequalities.
A powerful reminder. Well, if you found this deep dive useful for your revision or just your understanding, do check out PassTheMSRA.com.
And FreeMSRA.com as well. Both have lots more resources to help you prepare.
Great stuff. Thanks for joining us today for this important discussion on vitamin K deficiency bleeding.